Good evening, ladies and gentlemen, and I thank the organizers for inviting me to speak on this topic. And I think this is one of those things which we dread to have on our tables, but luckily enough, it is extremely rare. But once it happens, it is a significantly life-threatening complication. So the importance is in recognizing this early. And in my opinion, that every cath lab should be prepared for this at any given time, be it having all the kit that's required to ensure that this is something that should be picked up. And as we know, I'll talk about it later, there are certain cases or certain case subsets which have got significantly higher risk of perforations, and these need to be addressed, and the operators need to be extra vigilant when they're doing these kind of cases. I would start by saying prevention is better than cure, and I think prevention of coronary perforations is certainly something that one should think of. And I, having worked for the past 22 years doing coronary interventions, always believe that you should be starting your procedure with a non-hydrophilic wire, a non-stiff wire, or a sharp wire as much as possible, because 90% of your cases do not need hydrophilic wires. And non-hydrophilic wires are safe, they do not traumatize very much. And if you have a standard non-hydrophilic wire as your workhorse wire, you're less likely to perforate. And always look at the tip of the wire, and it's like telling grannies how to suck eggs. A lot of people who are senior clinicians, but for the younger ones who are down there, should remember that you should always keep the tip of the angioplasty wire in your frame all the time. Keep a watch on the hemodynamics. Perforations leading to hemodynamic compromise happens quite rapidly. So if you suddenly notice a surge in the heart rate, a drop in the blood pressure, or the patient becoming symptomatic, it is time to think, has something happened there? And all being well, your case has gone well, it's important to make sure that you have it at the back of your mind that have I caused any harm to the patient? So taking a picture of magnification, having a prolonged injection, and also panning for the distal vessels always helps, because this is the time when you can pick up any leaks and any extravasation of contrast. And if you have any doubts, then early use of echocardiography should be done promptly. And even if there is a doubt, the first echo does not show any changes, repeat the echo so that if there is any progressive and slow accumulation, you can pick it up before the patient crashes. And I think, as a rule of thumb, every cath lab should have a practice in motion of having a covered stent available, making sure that pericardiocentesis kit is available, and an echocardiography machine, if not in the lab, is quite close by so that you can look at it. There are certain characteristics, as I said, which increase the risk of perforation. This can be anatomical anatomical factors or procedural factors. If you've got vessels which are heavily calcified, if you've got extreme tortuosity, you have vessels which are low caliber vessels that you're trying to intervene in, chronic total occlusions, particularly those with a very blunt occlusion which do not have any clear collaterals, degenerative saphenous vein grafts, and I add this from my personal experience, which I'll share with you in a bit. And if there is a significant mismatch between the proximal and distal portion of your stenting segment, and you try to size it to the distal segment rather than the proximal, then these increase the risk of perforations. In terms of procedural complications, again, procedurally what could do, as I highlighted earlier, hydrophilic wires and stiff tip wires or polymer jacket wires are all things which increase the risk of perforation. Oversizing the balloons for pre-dilatation, or oversizing a stent, putting a stent at a 1:1 ratio, unnecessary high balloon pre-dilatation or even post-dilatation without looking into the vessel morphology, seeing if there's any extra calcification, and going up with very high pressures to get cosmetic clarity may also cause trouble. And stenting small caliber vessels or vessels which are tapering down, again increases the risk. And foremost of those who do rotablation, you would all agree with me that doing rotablation in extremely angulated vessels also carries a significantly high risk of perforations. When you look at the classification of perforations, there's two anatomical classification, and again the classification based upon the type of tear. The anatomical classification is either big vessel, small vessel, collaterals, or epicardial collaterals. Epicardial collaterals are worse. And when you look at anatomical classification, you've got 5 types. The 5th type is what is added by the European Society of European PCI group. The type 1 and type 2 are straightforward ones. You can see just a little bit of extravasation of the dye without any jets. The type 2 is with a blush without any obvious jet. These are usually very benign and can be sorted out. The type 3 onwards are something which can turn into catastrophes, which has to be addressed fairly well. In type 3, you can see a clear jet of extravasation. In type 4, you can see it extravasating into another cavity. And in type 3, usually it's a wire perforation or a distal perforation where you have a continuous jet going with the systemic flow. So management, I think you have got general measures and you've got specific measures. General measures, I think this is the time where you don't have to think, oh, who am I? I'm doing the angioplasty. I can do this. I can sort it out. It's always better to have another pair of hands and another pair of eyes. So shed your ego and call for help. Your colleague, the one you may not speak to every day, might be the one who will come and give you a hand and help you out. Look at hemodynamic support. Make sure that your patient is well hydrated. Ensure that inotropes are started off. And if it is a persistent leak, then see if you can get some blood transfusions or do some auto transfusions. If your patient gets bradycardic, then atropine will work. Have clear plans for early pericardiocentesis. Involve your cardiothoracic team fairly early, because if by the time you have 10 to 15 minutes of time wherein you can sort it out, and if things are going downhill, your cardiothoracic surgeon is the guy who can help you out. Always think about reversing anticoagulants, so you tell your technicians or your nurses to prepare for it, but don't administer it until you've got all the wires out. Specifically, I think balloon tamponade, this is the most important, the most simple, and predominantly most effective technique in ensuring the seal. Ensure that you put the balloon tamponade proximal to the perforation. Put it on a 1-to-1 ratio. There's no need. You're planning to stop the flow. Thereby, it should be a 1-to-1. It does not need to be high pressures. 8 to 9 atmospheres is fine. But importantly, keep it prolonged. Make sure at this time your patient is going to have pain, is going to be unwell. Give them adequate sedation, give them some pain relief, and so that one aspect of the problem is sorted out, your patient is comfortable. You could pass a parallel wire and a microcatheter, and you can address the perforation, particularly if it is distal perforations. You can plan for any coiling or injection of gel. So that's the block and seal technique that we talk about. Always have in your cath lab whichever technique that's available, be it coils, be it gel foam or adipose tissue, which you can pass through the microcatheter and seal it off. Some of you may have experience with thrombin that can also be given, but make sure that it is given with an over-the-wire inflated balloon, so that distally it occludes and it does not cause a massive MI. And as I said, covered stents is something that you need to keep in mind. Covered stents, you have to keep inside and make sure that it's inflated properly. There's another technique of double wire technique. I think you can look this up, as these are things that can be worked upon. So in summary, you have got a universal strategy. You inflate the balloon, you give IV fluids, you do pericardiocentesis, and you get the surgeons. If your patient is stable, well and good. If not, think of going further. I'll just finish off with a few slides about an interesting case you may not have seen. I didn't see this in my life until I had it on one of my patients. 75-year-old with post-CABG with symptomatic angina, came in with symptomatic angina. I did his angiogram, and you can see from this angiogram, let me go back on that. That he had significant native triple vessel disease. His left system was totally occluded, right was not very favorable. He had a patent lima and a patent saphenous vein graft to the OM. And he had this lesion, as you might observe. I don't know if you can see it very clearly from there. He had a tight insertional stenosis in a dominant right coronary, in a graft subtending the right coronary artery. So we decided to go ahead and deal with this. This was a straightforward procedure, 7 French catheter. Only thing that I did different was I took a hydrophilic wire as against to my usual practice, because I thought I get one chance and I'll go through it. So we placed a hydrophilic wire across the lesion without any major issues. And you can see that there's a small 2 millimeter balloon, 2 by 20 balloon, which is coming with contrast guidance, which crossed without any major issues. And this is after the distal inflation. I had the patient in pain, and you can see that he had a significant tear in the SVG graft, quite distal from the point of where we had done the ballooning. I don't know how many of you have seen it. I didn't know what hit me. So then we luckily had, I did call for help. A good friend of mine came and joined me, and we had a 4.5 balloon inflation for about 6 minutes, didn't settle down. We then found a covered stent, which didn't settle down. We had extravasation, we had a hematoma compressing the right ventricle, and then we took him across for surgery. My surgeons put a graft on and closed this tear. But unfortunately, the downtime was around 30 minutes, and he went into cardiogenic shock and persistent acidosis and demise 36 hours later. So in summary, ladies and gentlemen, coronary perforations is a challenge for any interventional cardiologist, be it a senior or a junior one. It requires a cool mind, a strong heart, and preparedness from the team. The management is, as I discussed, prolonged balloon occlusion, pericardiocentesis, keep a covered stent available, reverse the anticoagulation, and call a surgeon. Most important, have a team which will work together. And despite all of these things happen. It should not put you off, but I think at least, I hope at the end of this, you would have some thoughts about keeping your lab prepared for these procedures. Thank you for your time.